Hi, Deb. You are number one.
That's because I thought I would just sign in and then go do a couple things until we start.
That's what I'm doing. So I'm just gonna mute and go back to my stuff.
Sounds good.
And that's you've got YouTube on as well.
I do.
Or are you watching me on YouTube? No, you're watching me on Zoom.
Yeah,
So you've
I'm on
got
Zoom.
maybe oh, I have YouTube on in the background.
You have YouTube on.
Thank you. I'm gonna fix that. Thank you for okay. Bye-bye. There we go. Good morning, Deb, Gary, and Julie. I know Deb is working on stuff. She came on earlier and just hanging out while working and waiting. And Gary, good morning. And Julie Garcia. Oh,
How are you?
I get to be in a Zoom room with you, so I'm good.
It's beautiful out here today.
Where are you?
I'm at my home. This is the first morning in the last 7 months that I don't have to be anywhere except right here.
Lovely. So you're in your backyard?
Yeah, we're working on outdoor stuff today.
Good. Yes, it is a gorgeous day. I have a window. I can see blue sky and trees kind of blowing. It's very nice.
I know, I'm so excited. I was beginning to think summer wasn't coming.
Oh, yeah. Today is the day.
Yep.
Supposed to be like 80-ish.
Oh, it's amazing. I'm so excited.
So Julie, today you should be thankful for Zoom because you get to stay home and still go to a meeting in the morning.
It's true. I like Zoom. I miss meeting with people in person, but I really love Zoom because I get to meet with so many people and I can still do my work at the same time.
Yeah, so I miss a lot of in-person stuff, but I hope we keep using Zoom for a lot of the stuff. You know, it would save gas, it would save time.
Mm-hmm. Yeah, I assume like for this meeting, for the Homeless Coalition, there have been talk about being in person. Yeah, some people love in person, and I assume we'll do it at some point, but I am hoping that we can blend the two, because I know the entire world is thinking that through. Like, how can we have Zoom and in-person meetings because we don't want to give up Zoom, but some people like to be next to each other. So I'm sure we'll make it happen.
Well, my hope for things like the coalition is that we will like do 2 or 3 meetings on Zoom, and then we'll have an in-person gathering, you know, to touch people and have that. But
sounds good to me. I'm game for anything.
Because I know
Well,
some folks who are doing a hybrid Zoom at the same time they're doing in person, and those are very awkward. The people on Zoom just don't feel fully present.
Right.
You all are getting weird, awkward hugs when this is over. I'm just telling you. I'm missing hugging people.
Yeah.
I'm just gonna give them out weird, awkward ones.
Yeah, I miss those hugs. I have a few people in my life where we're all vaccinated who I get to hug. You know, that is so nice. Gary, what do you do?
I am an outreach specialist with Goodwill Supportive Services for veteran families.
Oh, yeah, good. And Deb, I should remember what you do, but what do you do?
I get paid to be a pastor, and then I'm also sort of a gadfly, subversive social activist.
Oh, good. Remind me where you're a pastor again. I know I've heard this before, but I forget.
St. Paul's and Liberty Park United Methodist Churches.
Okay, cool.
And then I have a ministry called the Oak Tree that does social justice stuff.
Oh, good. Okay. And Julie Garcia does just about everything. And runs Jules Helping Hands, and Jules Helping Hands does everything. And I just push the button and get to hang out with you folks.
Julie's gone past the gadfly subversive stage to the get it done stage.
She is boots on the ground, hands in the dirt, doing it. Yeah.
I'm trying to get back. I'm on the safe driving mode and I'm not driving.
Welcome, Christina, to the early networking high portion of our meeting. What do you do and where are you from and why are you here?
Hi, I'm Christina Taylor. Is it me that you were asking about?
Yeah.
The meeting.
Yeah, so I like to join early and then kind of do some other work until the meeting starts. But I've introduced myself a few months ago, but I work at Vanessa Behan. I oversee the intake department. So I like to be in these in these meetings to kind of, just so much networking and so much information, and it's so great because we serve a lot of, not a lot, but a percentage of our families are homeless, and so just trying to figure out the best resources and things that we can help them with to help, navigate through. So, yeah.
You're in your new beautiful building on Sprague, right?
We are. Yep. Yeah. So it's working out well. We'll eventually have room for 60 kids, but right now, due to budget and just staffing, we have room for between 20 and 24.
Yes,
So.
and I think I told you, if it wasn't you, it was somebody recently, I said, get that word out, because I think there's money in the community that will support more budget for you guys to get more babies in there.
Yeah, and we have a whole development department that works on fundraising and those aspects of, since we are 100% privately funded.
Mm-hmm.
But I think we just need more people to help get people hired because there's only 2 of us that do the hiring. So it's really just spending more time and being able to devote those hours to getting applicants and going through that process. So we're getting there, but it'll be a little bit of time. But yeah, I always enjoy coming to these meetings, so always super fun.
I have another question for you.
Yeah.
Can you talk, do you know about, and if you do, can you tell me a little bit? I know a little bit about, but maybe you know more about what's happening in your old facility.
Oh my goodness, I do. I can't remember the name of the organization. I've been told a couple times, but I don't remember on the top of my head, but it's for mothers who have just given birth, and they are, I think that they are babies who may be drug addicted or just have, and so it's, they have little rooms that they get to stay in, and it just really really intentional bonding time and just mother baby time for those first few days or weeks, while I think the mother hopefully, I don't know if she's tapering off of the drugs, or if hopefully, I don't know all the specifics, but it sounds like a really great program, and I don't know if they've opened yet or not, but
I think they are. I don't know much more than what you just said, but you've added a few little pieces to my knowledge of it, because I know I've seen stuff about it. I thought, ooh, that sounds really good.
Yeah, it sounds like an amazing program. And I think that the staff there, or that organization, works with the hospital, because I know the hospital has a really short-term program, like where the mothers can stay like for a few extra days in the hospital, bond with their baby, but this is maybe the more longer-term option. So yeah, it sounds really amazing. So I'm really glad that something really cool went into that space, because
yeah, when we talk about, and people talk about, like, we need to solve this homeless problem. I think a big piece of it starts right there at birth. If kids come into the world to an addicted mom, or to, into a terrible situation, it's like, all right, let's just kind of start grooming you for homelessness, kid. So yeah, the more that kind of supports we can give kids right from the get-go, I think the better downstream will be.
Oh, definitely. I 100% agree with that. I mean, we're a trauma-informed agency, and there's just so much information out there saying that, even just from that initial bond. And so if babies can bond with a caregiver, that just sets them up for so much more potential success than what otherwise could happen. So yeah, just working from in utero to that birth and the immediacy afterwards, and so it's pretty neat.
Okay, hope that happens more. Okay, you go back and do some work, Christina, before 9:30, and I'll say hello to other folks. Let's see. Karen Chavez, do you want to introduce yourself and tell us what you do and why you're here?
Hello and good morning. I had to fill up my coffee. I am with the Contact Center Northeast with DSHS, and I'm actually participating today as I'm shadowing Sasha. So it's kind of my first time in a long time being present for the coalition. I've been present in the past through the Native Project, but and I work financial, so getting people into resources, and really passionate about getting people into resources and doing what we can to address barriers and making change. So yeah, nice to be here.
Cool, thanks for being here. And like I tell sort of anybody that comes on, if you want to put in your name and contact info and a little bit about what you do, somebody might see that and say, oh, Karen works there? Oh, okay, I'll contact Karen.
Perfect. Thanks.
Okay, let's see. Now, Eric, I see you're here. Tell us about you. I know I've asked you this before because you come in early.
Okay. Yeah. Hi, Barry. Hi, everyone. And it's always interesting and rewarding to listen in on these calls. I'm Eric Williams, Community Partnership Director at Second Harvest. We're the food bank for food banks for 26 counties in North Idaho and Eastern Washington. We had been hopeful that when the first of the year came around and there was seemingly at least a glimmer of light at the end of the tunnel, that the need would be reduced. And in some geographic areas it has, but our distributions for January, February, and March, which 2020 were way above 2019, this year's are above 2020. And we have some anticipation, and some on the ground and some just feel that the need will reduce, but thus far it's not. And so thankful to, we are incredibly reliant on partners to help distribute the food and get it into the right places. And so we're deeply appreciative of that.
Well, put that in the contact as well, and you could put it in now, but I think as people come in, they can only see what is in the chat as they come in. So if you want to put in Eric Williams, Second Harvest, and we would love to partner to try to get food into people's hands. And same thing with you, Karen, if you put it in a little bit later and more people see it, you might get some contacts that way. And Eric, you make a good point that, that you see like, okay, there's recovery happening and things are opening up. But one metric is people still need food. So maybe those folks in that population are not recovering the way other populations are.
Yeah, that's precisely right, Barry. And kind of one of the bad news aspects of all of this is one of the best analogies we have is the 2008 recession. And not quickly, but relatively quickly, unemployment went down, employment went up, but food insecurity stayed way higher. As the employment situation got better, food insecurity very much lagged, like up to several years. And in no small part, it's because the people who needed it the most were kind of most affected.
Mm-hmm. Okay, well, that's good to know. Be aware of that. Let's see, who else do you want to say hi to? Rob Thompson, do you want to say hi, who you are, what you're doing, and why you're here? Don't have to, but you're welcome to.
Yes, I'm with Revive Counseling. I work under Lane Pavey, but I'm here in the capacity as a student at Whitworth. I'm actually doing a project on respite beds.
Oh, tell me about that project? Just figuring out where they are, how many there are, who they're serving, that kind of stuff?
A little bit of that. It's basically I'm supposed to make a mock organization that provides those services.
Okay.
So I have to come up with a board and that kind of stuff.
Okay. And are you aware of 4 of our presenters will be somewhat in that vein today?
I've already interviewed Julie. So yeah, I kind of have an idea.
So 4 of our presenters are from the hospital system. They're going to talk about when homeless folks are discharged from the hospital, where do they go? And respite is one place many of them should be going, and there's a lack of it. There's a huge lack. There's like a big, huge gap there where we have folks who are homeless, medically fragile, whether they're coming out of the hospital or not, a place for them to get some type, various levels of medical care. So is that, am I saying what sounds right to you?
Yeah, from what I've found out is that we potentially have about 11,000 homeless people and only 800 respite beds.
Mm-hmm. Yeah. And there's probably more than 800 sick, medically fragile, homeless people who could use them. Yeah. I'm impressed that there's 800 respite beds. That I would like to know more about that.
There's 800 beds in our system. There's approximately 20 of those are designated for respite.
Ah, okay. Yeah, that makes sense to me. Okay. Yeah.
Straight from the horse's mouth there.
Yeah, that sounds right, because I thought I'm not aware of that many respite beds. Okay. Good.
Wait. So now what's the difference again?
There's 800 regular beds in our shelter system, whether that's low barrier or regular barrier. And there's only approximately 20 beds designated specifically for respite patients. Out of all of our beds, out of the 800, there's only 20 that are respite.
And respite means that there's a certain level of medical care or treatment. I mean, not high level, but people are paid to be aware of and facilitate medical care and rehab and, stabilization. That's what a respite bed is versus a regular bed. It's just you sleep and you get up and you leave. Yeah. Okay. Let's see. It's 9:20, and I could just call on folks. If somebody really wants to jump in and say hi, I would like to learn. Lockerma, do you want to say hi? Who you are? What you're doing?
Yes. I'm Margie Loker, and I work with Molina Healthcare. And we also have respite beds at Hope House. So if you have a woman who needs one, you can always contact us. I'm not sure how many beds we have at the moment. I know we had a few. So, but if you want to contact me, I'll put my contact information in. I used to go to the Homeless Coalition all the time, but I haven't for the last year and a half since I've been home. And I just decided maybe I better reconnect, because I used to be there every week, every month, and was on the email. And for some reason I wasn't on the email again. So I got back onto it. And I am a community connector for Molina. So I was out in the field most days. At the shelters, meeting people for coffee and parks and trying to get their needs met. So
good. Glad to have you back.
Thank you. Good to be back.
I see Sherry's got her hand up. Yes.
Yes. So I am Sherry, and I am Executive Director, Community Coordinator for Spokane Valley Community Advocates. I sent the coalition an email on Monday. Was it received?
What did it say?
It was about the rental assistance event on the 14th of May that we're putting on. Because I didn't see it get sent back to me as a member of the Google group, and I'm worried that it didn't get sent out.
No, if you send it, you don't get a copy back.
Okay.
And I look at them all, and I have a vague recollection. I could go back and look to be sure, but
Okay.
I'm like 97% confident it did go out. I know.
Okay.
I send them out all the time. I don't get copies back. So if you're the sender, you don't get it back.
All right, because I sent it to you and to Greater Valley Network, and I included that we're having this Greater Spokane Valley County only outside city limits rental and eviction assistance. It's in-person help to do the portal application.
Mm-hmm.
It's at Opportunity Presbyterian Church at from noon to 7 on Friday the 14th. I am in desperate need of volunteers. Nobody signed up yet. I've got 4 people separately I know are coming for half the day, but I've got 2 shifts and a minimum of 16 a shift. And 8 of those are actual interview workers that need to have training beforehand.
Mm-hmm.
So I am in desperate need of volunteers. That's why I was checking, because usually if something goes out on the coalition, I get emails back pretty quick.
Mm-hmm.
And I didn't get any responses whatsoever. I included the flyer,
Mm-hmm.
and then I also included the volunteer information on a separate doc. And that had the link to the sign up forms. It had links to the training. You know, and I had separate forms for shift 1 and shift 2, which was 11 to 4 and 3:30 to 7:30.
Sherry,
I'm
will
just
you
in
send
need of
that to me
volunteers.
as well? Will you send that out to me as well? I have some volunteers that could help.
Okay. Yeah, we just need to be able to get them signed up so that the link is in the form and I'll send it to you. But there's a recorded training, and then Carmen from SNAP is doing a training on Monday at 8:30 for us. And I just want to make sure people are comfortable with the portal before we actually put them at a table with clients.
Okay, I'd suggest since you didn't get much of a response, send it out again, because normally, I mean, just to be sure, I just quickly checked my email. I didn't have time to look real deeply, but there's another program I can go into and actually see. But since you didn't get a big response, do it anyway. Do it again.
Yeah, because like I said, I'm desperate. I need 2 traffic control. I need a couple out front to do pre-screening. I need a couple rovers. And then the most important is the 8 people at the table.
Okay.
And they would need to bring their own laptop, have Adobe Reader on it or iPad, and go through the training. And that's, you know, it's only a week away.
Mm-hmm.
Everything is set except the volunteers.
Okay. And
I will send it again.
I also recommend, if you can stay around to the end, when we finish, what I normally do, I'll say, do we have any quick announcements? And then I'm planning to turn it over to the action group for a longer discussion to follow up with what they're doing, because they're doing a lot of incredible work. They're going to make a brief announcement at the beginning of the meeting about what they're doing. Then I'm going to give them more time, basically how much time at the end they want for the people to stay around. Yeah,
because like I said, it's set. Like SNAP is behind this. I've got City of Spokane Valley supporting me, and the organization. I've got Errol Anderson on board. I've got all these. It's all set.
Good.
I just need the people, because I have a feeling we're going to be busy.
Oh yeah.
And I can't be busy if I don't have the volunteers.
Yep. Good. I think you'll get it.
Okay.
At least fingers crossed.
Yeah.
A few more minutes before the official meeting. Anybody want to say anything in particular? If not, I will just call on a few folks whose names are on here to say hi and who are you. Sarah, hand up. Go, Sarah.
So just want to put it out there that there's an LGBTQ survey that just went live this week. And so please share it. It's basically the discussion started with the high rates of our LGBTQ community committing suicide. And we went out to the community and said, what are the barriers? What's the issue? And everyone kind of came together and said, we don't have data for this population. And so we partnered with the Health District and Multicare and Empire Health Foundation and Kaiser Permanente and Spectrum. And so Spectrum has really helped us in terms of, you know, what's the appropriate language? What are some of the questions to ask? And so this is, you know, LGBTQ barriers to housing, to food insecurity, to safety, to health. So we're just really trying to ramp it up so we can get enough voices. This isn't, you know, we want allies to share the information, but we really just want the LGBTQ community to answer this and tell us their experience for Spokane. So if you haven't seen it from the Spectrum website or Spectrum Facebook page, I think I might have it and I can post it on here, but please share. We want as many of those voices heard as we can get.
Yep, I'll second that. Spectrum's a great organization. All the partner groups are top-notch groups. The survey, I looked at it. It's a really good survey, asked really good questions. So yeah, I second all that. Anybody else want to raise a hand or get in something before the official meeting? Let's see, there's a name on here. Keisha Kilgore. I hope I'm pronouncing it right. Do you want to say hi and who you are and what you do?
Good morning. I am Keisha Kilgore, and I'm actually a student at Eastern Washington University. So I'm in my master's program, and I am here this morning because we are doing a group project on homelessness. So we're in the very early stages of it right now, but our scope is kind of talking about rent cap and what we can do further on down the line, you know, to prevent homelessness and, you know, to keep people from going back to being homeless. So very early stages, but it's for a policy class. So
good. Thank you for doing that. I love it when people working on their masters take on these projects, because that helps move the conversation along.
yes, I'm very excited to be here, and thank you for having me.
Yeah. Let's see, I just see Kara Ready. You put something in the chat. You want to talk about it a little bit?
Sure. I just I've been coming to these for the last few months, and I just every time I want to get the word out about the where I work, which is the Spokane Regional Behavioral Health Ombuds. So we assist individuals with resolving concerns about their Medicaid funded behavioral health services in the Spokane region. So if you have a complaint, a concern, you need information or referrals, that's something that we can provide. So I put the website down as well. We also assist individuals with behavioral health advanced directives. So you can look for us online. Our phone number is 509-477-4666.
Great, thank you. Good to know. Anybody else want to say anything?
Hey, Barry. Hey, Barry, this is Carol Welks.
Go, Carol.
From SNAP. How are you?
I'm great. Good to hear your voice.
Hey, yeah. Hey, I just wanted to say, you know, we've got the emergency rental assistance program for Spokane, and a lot of people have got applications in. We're about finished up with the ERAP program and have just brought on 9 more people to process files. So things should start moving here sooner. Although the wait list is closed for the rental assistance, you can still use the self-service portal at rentalassistance@snapwa.org to apply. And we also had the new TRAP group, the Treasury Rental Assistance Program. We just got that contract. So that means we have about $18 million in rental assistance that's available. So feel free to help people do the online portal. It's a great way, an efficient way to get it done. So, and just so people know, when they put in a file, the first time they're going to hear from us is if they're clarifying something on their file. And if everything's good, they're just going to send them a postcard to both the landlord and the tenant to say how much the grant is.
Okay, great. And the easy place to find that is go to SNAP.
Yeah, rental assistance at snapwa.org.
Yeah, good. Does anybody else want to make well, no, my clock says 9:30-ish. So Robert, do you want to take it away?
Yeah, definitely. Welcome, everyone. Glad to hear everyone is sharing beforehand. Thank you for participating in this time that we have together each beginning Thursday, first Thursday of each month. My name is Robert Lipman. I'm basically serve as the host and chair of the Spokane Homeless Coalition, along with our fellow leadership members as well. Wanted to begin off by just kind of reminding everyone kind of what the Spokane Homeless Coalition is geared towards, and that's specifically planning, education, and communication advocacy on certain levels, and then also collaboration with one another. And I want to go over some virtual etiquette as well, as we all keep our microphones muted for any background noise. And any questions that you have for our presenters, just throw them in the chat box, and I'll do my best to monitor that chat as we go on. And then the Google Groups, another point is I want to remind everyone that this is a forum to dispense information, collaborate in regards to patients, clients you're working with, and encourage and not criticize each other. But this is a platform to basically collaborate the best way we can. And with that, I want to kind of skip the reflection today, but start off with moments of collaboration. And I like to leave the virtual microphone open, if you will, for opportunities where you saw over the past month, areas where, hey, I connected with this agency very smoothly. And one, for an example, right now, if you, a good moment of collaboration that our clinic had. I worked with a Providence medical group in delivering medical care to the poor and the vulnerable as part of Providence mission. But one area of collaboration that we've been able to assist in is partnering with Rosemary Ware and the Disability Assistance Project. She would actually make an announcement right now, but she's right outside my window providing services right now as we speak, assisting patients with social SSI and SSDI claims, getting the initial process going, and then assisting them with following through. So she's going to be here at our location every Thursday morning from 9:30 until noon. So if you have patients or clients who are working through that SSI, SSDI claim or just get stuck, this would be the place to send them. Our clinic is on the corner of 2nd and Brown. But that's kind of one of those moments of collaboration that I was talking about. So I'll leave the virtual mic open for a couple minutes for individuals who want to share those moments of collaboration.
So I want to go. Can you hear me?
Oh, yeah.
So this is Dawn Schuster. I'm part of the Stop the Sweeps Action Group. And I wanted to, for people who don't know, we formed, we're a collection of members of the Spokane Homeless Coalition. And we formed just right after we had an after meeting after the March Spokane Homeless Coalition meeting. So only 2 months ago. And we're a small group, but we're mighty. And we've met at least once a week since then, and sometimes several times a week. And we've basically put together a petition asking the city to change the way it treats individuals experiencing homelessness. And we have 6 asks, and all of the asks in our petition can be implemented immediately. So I want to talk about collaboration. We've collaborated in different ways, 4 different ways. The first is that we just as a group are a collaboration of a bunch of members of the Spokane Homeless Coalition, community members, homeless advocates, people with lived experience, members of the COC, SRHD, and the League of Women Voters. And we all got brought together by this Spokane Homeless Coalition, which we loved. The second way we kind of collaborated is after last meeting in April, we received some feedback on how to improve our petition and our reasons behind it. And we kind of reworked it, and we really feel like we improved both the petition and the document that backs it up. The third way we collaborated, which is the big one, is we were invited to table at the Humanizing Spokane March, and I don't know how many people went, but it was an amazing event. And that was 2 weeks ago. So we got to table there. So we just had this group of people that were all so supportive of our demands on our petition. And we got 210 signatures on paper there. So many different members of the community signed our petition, and it was kind of fun. I was walking around and people were like, oh, I want to sign it. I've been waiting for you to come by. And so that was exciting. And then the fourth way we've experienced collaboration is we've asked community organizations to sign on to our petition to kind of make it more powerful. And to date, the League of Women Voters, the Tenants Union, Jules Helping Hands, the Cat Lady Outreach, and the MAC Movement have all endorsed our petition. And we also ask everyone here that if you're part of a nonprofit or a community organization, that you ask if your organization will sign on and endorse this. So at this point, our petition has over 800 signatures, 300 online and 500 on paper. And so just to continue that collaboration, the last point I'll make is we would love everyone here to go online right now, either or after the meeting, after, when you're not focusing on the meeting, go to Stop the Sweep Spokane, either our website, our Facebook page, or our Instagram, and sign our petition electronically. And finally, the last thing that we're going to do that we're going to need collaboration for is we hope to present at a city council meeting in the next month, probably in the next couple of weeks. We want to get on the agenda, and we want to present our demands and also have testimony from people, especially with people with lived experience who have personal stories about sweeps and needing bathrooms and facilities and storage and things like that. So if anyone is interested in either joining our committee or testifying or signing, let us know. I mean, you can just sign online, but and we're going to be talking more after the meeting. So thanks for giving me this time to talk about all the collaboration we've had.
Awesome. Thank you, Dawn. And again, they'll be meeting post this meeting if you don't have any meetings. So I'll give time for one last one. If anyone wants to share. Going once, going twice. All right, we'll move on. So we want to dive in with updates. So it's been amazing. Speaking of kind of putting all these fragment pieces together, had the opportunity to give you guys an update as far as updates from the Continuum of Care, the Spokane Regional Health District, and Mr. David Lewis from the city, as far as providing us monthly updates. So I'm very excited and stoked to have them on. And first up with the update is Ben Stuckert. Are you on with us today?
I'm here.
Perfect. You want to give us an update on kind of the COC and kind of what's working in that?
Or not working because there's not enough resources for people, but we can kind of approach that a little bit. But so my name is Ben Stuckert. I'm the executive director of the Low Income Housing Consortium and the chair of the Continuum of Care, which handles the $4.3 million in HUD funding that comes through our community. In mid-June, the COC will have its 5-year homeless plan updated and brought out to the community. I don't know if you guys talked about this before the meeting started, but what's really exciting is Transition has partnered with VOA to offer temporary young adult shelter, which is for 18 to 24-year-olds, which has been a need in our community for the last 20 years. The permanent location is still being cited, but it's really excited to see that moving forward. It was really excited to see the Hope House open and all the work that VOA has done in that. Those are huge wins for the community, for both our homeless population, but to help stabilize people. I kind of want to talk real quick about one of the programs in our community to rapidly rehouse people, and the COC funds that program. And rapid rehousing, the agencies that do rapid rehousing have not been able to spend down that money. And I think it's kind of an example of our system and how it works. So rapid rehousing, if you go into coordinated entry and you're able to maybe stabilize yourself with your first and last month's rent paid, or your first 2 months rent paid and your down payment, rapid rehousing uses cash in order to offer that, and then you would be permanently stabilized in that market rate apartments. But so this has nothing to do with low income housing, this has to do with market rate apartments. And because we're at a less than 1% vacancy rate in market rate apartments, not only are apartment rates rising, the last month the average apartment in Spokane rose by over 5% in 1 month. In the last year, they rose over 14%. And so what that does is makes market rate apartments unaffordable for individuals. I just saw some new apartments up by my house that opened 12 units. They're renting for $1,500 a month, which if you think about that, that's a hefty mortgage on a house that you're paying to rent an apartment. But that's not affordable for somebody if we look at the service industry that is primarily the employer in Spokane. But we have such a lack of any market rate apartments available in Spokane that the rapid rehousing dollars, which is one of the most effective solutions to end homelessness when somebody becomes homeless, if you can just stabilize them in an apartment, is not available, and we're not able to spend those dollars. And so they're going to other emergency services in the system. Those dollars aren't getting turned back to the government, but it does point out a huge problem. So when we talk about homelessness, it's not just about the 5 to 6% of our housing stock that is subsidized and low income. It's also about our market rate apartments. And so when we look at problems holistically, we can't just focus on shelters. We can't just focus on low income housing, but we also need to look at our entire housing market, which I think is really important to keep in mind, because if decision makers are making decisions not to build or allow more apartments, what that's doing is creating the shortage of units for people to rent, and prices will rise. Last month alone, so and houses are the same way. There's no stock available for houses. And I just want to give one recent statistic I got yesterday, which is from March of 2020 through March of 2021, home prices in Spokane rose by 18%, which is a crazy increase anyway. But in 1 month, so from April of 2020 to April of 2021, so a 1 month difference, the average increase in that 12-month period of a median home price in Spokane is 29%. So in 1 month, prices rose, the average median household price rose by 11%. That is completely unsustainable. We do not have wages rising at anywhere close to any of those numbers at all. So it's becoming unaffordable for people to own homes. It's becoming unaffordable for people to rent market rate apartments, and you can't build low income housing. There's been massive cutbacks at the state and federal level. And so one of the things we were discussing was, do we need a better intake system in the homeless system? And can we shift money to the intake system? But the intake system, the agencies that run that and the people that are on the ground doing the work actually said, if there's no housing at the end of the intake system, you're just intaking more people with nowhere for them to go. And so we need massive investments in low-income housing, but we also need to invest and figure out how to densify our city so that there are more units for people to get into so we can keep those prices down. And I did hear earlier Humanizing Spokane mentioned. I just urge everybody to go check out that website. Just Google Humanizing Spokane. But those students are doing great work and making great demands. And the Stop the Sweeps movement had an excellent presentation at the forum. So that kind of goes into my next thing, which I was having some conversations because the county is getting $100 million in local government CARES Act dollars. The city is getting $84 million in local government CARES Act dollars. So I've been meeting with the subcommittee chairs of the COC. I had a meeting with the League of Women Voters. I've had 4 meetings with the commercial real estate group that has popped up that wants to affect homelessness in our community. And we're about 2 weeks away from having a final plan that would be significant investment that we will be taking to the city and the county in early June. It includes all the elements of the Stop the Sweeps demands, but it's also more broad where it includes $40 million in investment in housing, in low-income housing, but also includes other capital expenditures inside of the homeless system. It would cost about $9 million annually in operational costs in addition to what's being spent on the system, and about $48 million in capital investments. Once I have that final plan in early June, I will come and that'll probably be my update in early June. But we're trying to meet with as many stakeholders, but also as I've created this and worked on it, I have taken all the suggestions that I've seen from Stop the Sweeps. Council President Beggs had his own plan that he presented. I took elements from that, and we're almost to a point. I know the League of Women Voters, Dawn, had suggestions that I incorporated into it. But this will be a significant investment that once I come present, I'll be asking you if you can all get behind it as well in a press conference in early June. So that's kind of a COC homelessness update from my perspective.
Thank you for that input, Ben. Hope everyone was taking notes, and if you have any questions, direct them on the chat box, and hopefully Ben can stay on for a little bit and answer anything that comes up. Thanks, Ben. The other next one would be the Kylie Kingsbury. Are you with us as I heard? So Kylie is from the Health District, giving us an update in regards to the vaccination, how that's going. I know there was a little hiccup in the past month with the Johnson & Johnson. Maybe you could give us a little update.
Yeah, I'm happy to be here. Thanks for having me. It feels like it was forever ago with the J&J pause. But I think from our end, that pause was a positive thing in general. It's showing that the CDC is really keeping tabs on the safety of the vaccines. And so with 6 people in the 7 million doses having those responses, it really is evidence that even just a small amount of reactions can be really pushed up high and to really make an impact. Now that the J&J pause has ended, there is a caveat that women under 50, there is a very small risk of blood clots. And so what we are doing at our vaccine clinics is offering the Johnson & Johnson vaccine as well as the Moderna vaccine. We wanted to make sure that if clients really wanted to advocate for themselves, and if they fit in that age grade or age range and just really didn't want the Johnson & Johnson vaccine, that we had other options available. And so we tried really hard to make sure that we would have those options available for community members who just in general are having a little bit of a harder time getting access to those vaccines in traditional settings like the mass vaccination sites and clinics. I think that has been really successful, and we are still finding a lot of people day in and day out. We're doing, it's about 4 days a week clinics right now, and we're every Monday we're at the SRHD needle exchange, and on Fridays we are at the SRHD methadone program. And so those are our set clinics that we offer both vaccines at, and then throughout the middle of the week, we are rotating around sites in Spokane, meal sites, outreach outreach areas where meals are being offered, as well as shelters. And we are currently at 798 unique individuals who have been vaccinated. And the large majority of those are fully vaccinated. I actually counted before I got here, and it's less than 100 people who are late for their second dose. So we're still trying to find those people to make sure that they can get that second vaccine. But the Johnson & Johnson is a great resource too, because it's one and done. And so finding people for their second doses, it takes that piece out, and then it gives us more time to find new people who haven't gotten the vaccine yet. I'm sure David might talk about it a little bit, but the SRHD has partnered with the city to add a really cool function to CMIS, where shelter providers are going to be able to access vaccination records of their clients so that they can get a good idea of herd immunity rates within their sites. And it'll also give us a good idea of how many people are vaccinated who are accessing emergency shelter beds, and how much further we need to do in preparation for the fall. It was pretty rough last fall in our shelters with a lot of cases. And so I'm hoping that our big push in our community to get people vaccinated will take steps in preventing that so that less people can get sick. So really excited about that. So thanks to the city for helping on that.
Yeah, thank you, Kylie. And can you put in the chat box those locations again?
Yeah, would love to. And I'll put the times too.
Awesome. All right, Mr. David Lewis, our first presenter has some limited time. So if Mr. Lewis, if you could just keep it brief, I want to be able to make sure we get, if you guys have the agenda, we have Providence person speaking on hospital discharge. So Mr. Lewis, so you are up.
Thank you. And I will keep it brief. I just wanted to provide a couple updates, and it's nice because I think some of my updates align with what Ben had shared and what Kylie had shared. So that's always good. So everything Ben said, I can't emphasize enough how spot on that is, given the challenges we're seeing locally with our flagship intervention, which is rapid rehousing, which is so dependent on available inventory to put people. So one of the needs that we're looking at addressing, and I know some of you may already be aware, is what can we do on the prevention side? And one of the strongest tools at the moment available to us to prevent those that are at risk of becoming homeless from becoming homeless is the emergency rental assistance that we have going out. And at this moment, we have 3 providers that are under contract, which would be the Carl Maxey Center, Family Promises Spokane, and Live Stories. And they're expected to be up and running and accepting applications very soon. We will also be releasing another RFP for, I believe it's somewhere between 6 to 9 million in additional rental assistance funding. And the goal with that next RFP is going to be similar to the first one, but even more intentional. We want to make sure that we are engaging with BIPOC communities and non-English speakers that have been disproportionately impacted by the rental assistance crisis. So the data is definitely indicating there's great inequity there. So we want to position this RFP so that we can partner with those organizations that are targeting that group so that we're getting the maximum number of dollars where it's needed. So that RFP is expected to go out soon and will be available. And so hopefully, if I don't want to wait a month to provide more updates. So if I get updated information, I'll share that. And my last update, I wanted to touch on seasonal sheltering. That's something that we're trying to get ahead of now, looking at kind of a multi-layered plan there. We are going to have seasonal capacity at the Way Out shelter, which is going to be undergoing renovations as it transitions to a bridge housing model. So it's going to be about a 14 to 16 week process as the construction is going to be underway there. We're going to be looking at temporarily relocating TSA potentially to Cannon or other ways of expanding bed capacity so that we don't have too much of a shortfall while construction's going. But moving into the fall, we're going to have seasonal capacity at Cannon. Long-term plan there is a flex use site. So day shelter services and emergency shelter services. So we'll have seasonal capacity at Cannon, seasonal capacity at the Way Out. And what I'm advocating for and working with the CHHS team on is developing yet again using hoteling as an option to meet overflow needs heading into next winter, as well as strategies, thanks to the work Kylie and Regional Health District is doing, different strategies where we can scale capacity at existing shelters to accommodate those that are vaccinated versus non-vaccinated. We know we had all these different health requirements that we had to address last winter, and COVID's not going anywhere, so we have to be prepared for it this winter. But I think due to all the vaccination efforts and the amazing work that Regional Health District is doing, we may have some opportunities to prevent capacity lost as a result of those health guidelines. So those are my updates. I hope I didn't go too long, Robert. I'm sorry if I did.
That's okay. We are just on a roll. So if you have any questions, please chat Mr. Lewis in the chat box, and I'll send them over that way.
Yes, and I do have to drop off in about 10 minutes, so you can always email me your questions too.
Awesome. Thank you, David. Awesome. So we are going to jump into the presenters. We have kind of this perspective of hospital discharges as kind of our theme. When we come across, I work with Providence as well. And so we are an organization that emphasizes serving the poor and the vulnerable the best we can. And so one of the topics that came up was hospital discharges, not only on the Providence end, but we have someone from Multicare as well to kind of give their perspective on what that process looks like internally when patients who are experiencing homelessness come into the ED, or if they're admitted, anything that resembles that. So we're going to kick off with Kimber Bowen, who's another Providence worker, a hospitalist who is up at Sacred Heart. And Kimber, are you on the line with us?
I am. Hi, Robert. Thank you.
Thank you so much for taking time to kind of give us a brief overview of what that process looks like. And I'll probably just start off with patients who are admitted. So when someone who's experiencing homelessness is admitted to Sacred Heart, and then it gets like if they go through the emergency department and it's deemed that they are admitted into the hospital, they go up to the floor. And then when it comes time for discharge planning, what does that discharge plan looks like? From does it fall on the doctor to start that process? Does it fall on the RN? Does it fall on the social worker? Who starts that discharge process?
Okay, so the discharge process actually starts the minute they walk through the door from the nurse's perspective and the doctor's. They're assessing and looking at where they came from, what their supports were. If it's a homeless patient, they tend to make a referral to social work, because the social worker is the one that does all the discharge planning for the hospital. We then get that referral and start touching base with the patient. We go in, do an assessment, find out what their situation is, what their resources are, where they came from, what they want. We provide resources if they want them. Some don't. We talk about other options in terms of like other housing, home and community resources, things to that effect. And it really just depends on where they're at that moment and what their interests are. The difficult part is we tend to not be able to keep patients just sitting in the hospital because they are homeless when they came in that way. We can provide all the resources available, but they have to accept and utilize what's available to them. When the doctor tells us that they are medically stable and ready for discharge, we then have to make sure that we have a safe enough discharge. And if they were previously homeless, living on the streets or in the shelters or, whatever they were doing, that is considered safe enough because that's what they came from. That's what they were doing. If there was medical concerns, wound care, things like that, we set them up with our respite shelters at House of Charity or Hope House so that we can have home health come in and see them. So we tend to do that frequently. And again, when they're either psychiatrically or medically stable, we just look at a safe enough discharge and move them back on to where they came from. Oftentimes we have folks that refuse anything and choose to just go back out to the streets, which is their choice to do that, and we respect that. There's so many little caveats to all of this. I couldn't even begin to explain every single situation. If they don't have capacity, if they're not safe, if their wounds are too significant, we're certainly looking at other plans. We're looking at placement in nursing facilities or whatever the other options might be.
Yeah. And part of our goal at the coalition is to kind of mend all those fragments together. One other question that I had real quickly, I know your time is pretty limited, but is regards to medically stable. You'd mentioned the doctor when they find them appropriate to be medically stable. From your experience, I know you're not a doctor, but what has that historically looked like as far as that medical stability before discharge?
And that's a hard one for most people to understand because the general community would, let's say, this patient's not stable. But from the hospital perspective, from the doctor, is they no longer require acute level of care. So we're not actually medically treating anything acute illness. That acute illness was treated, and therefore they no longer required to be in an acute hospital. That doesn't mean they're still not sick or they're still having difficulty walking or, other things to that effect. But from the medical professionals, it truly means they no longer need to be in the acute hospital.
Yeah.
And that's look at then moving them on to the next level of care if we can. There are so many barriers to that issue, though.
Definitely. Yeah, I experienced those here at our clinic because we're a walk-in clinic to treat some of those discharges who may still be sick or wounds or what have you, or even the street medicine team being able to go to where they came from, basically, if they're experiencing. Well, I know you have another meeting to jump onto, Kimber, but thank you so much for giving us some of your time to give us a little bit of background and definition of what that looks like on the Providence end.
Absolutely. You're very welcome. Thanks for having me. Have a good day.
Thank you.
Bye-bye.
Bye-bye.
Bye.
All right. So now we up next, we have in regard, Chuck, are you with us?
Yes, I am. Hi there.
Awesome. Chuck, can you give us, I know you from like hot spotters and other things involved with the working with this population group when talking about health equity and population health, all that stuff. I've seen you at a lot of places. Can you give us kind of what your role is and where you work at?
Sure. Yeah. So my name is Chuck Hankey. I am the social work supervisor at Deaconess Hospital, Multicare Deaconess. Been here about 4.5 years, and then prior to that, I worked with at Frontier Behavioral Health for about 10 years prior to that. So, yeah, I mean that's the basic rundown of me.
Perfect. And with after listening to Kimber kind of give a rundown of the discharge process. On MultiCare's end, how can you kind of relate to what she was explaining? Are there any differences? Maybe walk us through kind of the same process as when a patient presents in the ED or is just taken AR in and admitted into the hospital.
It sounds like our processes are pretty similar. Kind of the discharge planning starts at the admission. Is true, when someone gets admitted to the hospital. We have our setup here is a little bit more focused on nurse case managers, and then social work is given a referral if there's perhaps a substance use history, behavioral health history, things like that, so that we can then also help out with the case. But a lot of our dispositions are driven by our RN case managers. But we meet with someone when they come in, we assess their previous living situation, different things that they have going on. And then we start looking at what the options are going to be for their discharge. Once they're getting here, what avenues are we going to be able to take? And so, a lot of what gets decided in a discharge plan is what's medically needed, and then also what's possible with the resources that we have. So we're always looking at what is this person's home environment and what would it take for them to return there safely and to be stable there, because that's what's going to be best for them and best for everyone involved. And what happens with a lot of cases is they may not be eligible for certain levels of care. And so we try and do things like send someone to a house of charity respite bed with home health. And then maybe the home health agency calls us a couple days later and they say, hey, we're not able to actually take this one that we thought we were going to. And then that's kind of when they come in to, see you at the walk-in clinic. And then you give me a call and say, hey, is someone supposed to be following up with this guy? And we got this wound, we got this and that. And so sometimes what we're looking for is a reasonable discharge, and we try and line up all the resources we can, but it doesn't necessarily mean that they will follow through. It doesn't always mean that the agency followed through with exactly what they said they were going to do. And so then sometimes we have to kind of reconfigure things when people are back out in the community. And so some certain things like placements at skilled nursing facilities and different things like that can be difficult for us to arrange for individuals who are experiencing homelessness, because that skilled nursing facility has to find a stable place for that person to go afterwards, and shelters don't count according to their regulations. So we have been able to, on occasion, use a house of charity respite bed as a step down for someone to go to a skilled nursing facility and then go to house of charity respite bed. That has worked a few times before, but that is one situation in which people who are experiencing homelessness can have difficulties getting to that type of nursing care that they might benefit from.
Right. And what is there like certain criteria that social workers or RNs go over prior to discharge, like they meet X, Y, and Z, or they're functional in these type of things before either sending them to these respite locations? or even within the shelter, like if you're calling one of the shelters, you have a bed open, not necessarily respite. But what does that functionality look like?
Yeah, so it's, the timeline is it's a little bit longer if they're admitted to the hospital. So that gives us a little more time to see, physical therapy, occupational therapy, what kind of level of functioning do they feel that they have. Like Kimber had said, the medical clearance part or medical stability is kind of a relative term because it depends on where they're going. They can have more medical needs if they're going to a more medical facility. They can have a little bit more medical needs if they're going to a respite bed as opposed to a general population bed at House of Charity. So sometimes it's always clarifying with the doctors or the nurses or with the providers in the community, okay, this is the level of functioning that this person's at. Can they maintain in this environment? So there's kind of that back and forth, because a doctor may feel okay, discharging someone to one environment, but not to another. And it's sometimes being able to manage that case and figure out, what exactly is this person's level of functioning and can they function there? Because, certain things can be tricky, like bunk beds, at Hope House. So we may have someone who's good for a bottom bunk, but not for a top bunk. And we have to get that feedback from the shelter and then talk with the doc and talk with the patient themselves to see what's manageable. And so sometimes that communication happens very well. Sometimes it doesn't happen as well. In the emergency department, it may be, they said they had this place to go and we trust that and that's where they go and things don't work out. But for the most part, yeah, it's always kind of navigating those different levels of functionality. And then, some of that just goes by what we've experienced before. And some of that goes with communication when we're talking to the facilities or talking with the doctors.
Yeah. And do you think kind of the providers who are the hospitalists working in there, do you think their perspective will change now that social determinants of health is considered more prevalent as a medical kind of function within the healthcare system? Do you think their perspective will change when it comes to discharge or
I think it will. I think it will gradually do so. I think it will be more with social work and case management, bringing that into the fold more and more. I think is what changes it, because the doctors kind of focus more on the medical stuff and then we kind of bring in the rest. And so I think it will gradually work its way into our conversations more and more. But yeah, I think that's.
And for those who don't know, can you explain kind of what social determinants of health is?
Well, I don't know that I'm great to speak to it yet. We're just starting to implement some of that stuff. So I know that it's been implemented more on our west side with multi-care, and so we're starting to look at it more, and our outpatient facilities are starting to review it more, but we haven't been implementing that yet on our inpatient side.
Yeah. Okay. Well, thank you so much again for your time and willingness. And if anyone has any questions to Chuck, maybe Chuck, you put your email in there if you're wanting to touch base with anyone or vice versa. That'd be helpful.
Yeah, sure. All right. Thank you much.
Closing comments before?
Nope. Just always feel free to get back to us with feedback on things that work well or didn't work out. I know that you and I have obviously had to work out several different scenarios that kind of went awry and trying to figure out where things happened or miscommunications happened or follow-up didn't happen with various agencies and stuff. And so being able to look through that stuff is always good, because you don't know where those gaps are until someone points them out. So
yeah, and I know, definitely speaking on behalf of our clinic here, is that if you folks who are either receiving patients or seeing patients on the street, a good opportunity to triage those patients is by having them come into our clinic, so we can assist, rather than kind of playing this circled loop with the hospitals, because I know, and same, Chuck is aware as well, to send patients to follow up with our clinic, and so is Kimber. But definitely want to utilize the resources that are available for our population group. Thanks again, Chuck.
Yep, thanks for having me.
Yeah. Next up, we have Amy. Sir, are you with us, Amy?
Yes, good morning.
And did I say sir? Is that correctly?
It's actually sear, like you sear a steak, but it's okay. Everybody mispronounces it.
Okay. Amy, it's nice to finally, we both work in Providence, and I don't think we've actually met face to face, but always go back and forth on our teams communication. Thank you so much for being with us, Amy.
You're welcome.
So I'll just give a kind of a brief overview of kind of Amy's role in this. So with the hospitalists, we just kind of spoke about, Kimber and Chuck both spoke about kind of the discharge process. And in that process, they had mentioned home health. And so this is where Amy comes. I'll let you introduce yourself and kind of your role within Providence.
So my name's Amy. I'm actually a PT by trade, but I'm one of the clinical managers at Providence VNA. I've been here for almost 8.5 years. And I supervise what's called the central area, which includes Hope House, House of Charity, some of the downtown Catholic charity buildings, and some of the, homeless population, et cetera, and the clinicians that go to those facilities. And so if we get a referral for patients that are in those areas, I am one of the ones that help supervise those clinicians and those clinicians that see those patients. And we provide the various services that they may need under their doctor's orders from that referral.
And can you kind of, so those referrals, I imagine, typically come from, and when they're discharged from the hospital, is that?
Yeah, so usually when they go to the either Hope House or the House of Charity respite beds, we usually get them from the hospital, is what usually happens. And then we would go out and assess them and admit them to our services if it's appropriate.
And how long typically are patients enrolled in your, and what does VNA stand for, I guess?
Well, it's Visiting Nurses Association. So it's Providence VNA Home Health is what we're technically called by Providence. And patients can be on our service for a day, and they can be on there for longer. So it depends on the patient's needs and whether they stay at the respite shelters or the homeless shelters or not, or if they're exited from their programs, et cetera. We have criteria that we also have to use in order to be able to see them. We provide, I see in the little chat over there, we provide nursing services, physical therapy, occupational therapy. We have speech therapy. We have an occasional dietitian that we can use if needed. We have chaplain services. We also have a social worker that we can utilize. We work very closely at House of Charity Respite with Robert and the clinic, as well as the respite coordinators and all of that staff, as well as the Hope House people to try to help that staff. And we have specific staff that we try to keep going there to keep those relationships involved and appropriate, so that we have consistent people going there to see those patients.
Continuity of care. I love it. And what you were just about to dive into the criteria. So what criteria make someone eligible for you guys to step in?
So in the big scheme for home health, and so I'm going to do a couple little caveats because it's a little bit different from this type of population. So one of the big ones is you have to have physician orders. You have to have a following physician. One of the hard things that we find sometimes is finding a physician that the patient has seen or will follow in the homeless population. So sometimes we have to do some coordination of care with like the teaching clinic or other various avenues and working with the respite program to make sure they're getting to a physician or have a physician. Usually our hospital coordinators work on that up front, but they have to have a physician that's going to follow them and sign orders. One of the criteria that insurances require is what's called homebound. Now, in theory, that's a little bit different in the homeless population because they may not have a home, but if they're at the Hope House or the respite program, we consider that their home. So they have to be willing and present for appointments. We've had lately a lot of patients at the respite program at the House of Charity that have been missing. So they'll leave at the very early end of the beginning of the day and they won't come back till later in the day. And if they're not there for us to see them, we can't see them. So they have to be able to be willing and available to see us. It has to be safe, has to be a safe environment, has to be a safe situation for us to be there. So we prefer them to be enrolled in the respite parts of it. Just seeing the general population, because of the more controlled environment of the respite program, we know that they're going to be present there. You know, it's a little bit more strict environment than the general population kind of coming and going. So we're able to see them there. So there's just kind of a few criteria that we have to use, including skilled care. So they have to have something that we're doing from a skilled standpoint, you know, whether it's, you know, improving their mobility, they have wound care, we're doing something skilled to be able to provide our services.
And one of the questions on the chat box, and again, I'll encourage everyone to mute your mic if it's not, but one of the things that folks on the streets have trouble with is keeping track of times and dates. How does VNA help unhoused people with this issue? Or can you?
Well, unfortunately, if they're not in a house, like if they're just living on the street, we can't necessarily help them or we can't see them because we have to have a safe, I would say, home in this respect, like House of Charity, Hope House, etc. They have to have some type of home that we can safely see them in. So we can't just, find them somewhere. We have to have a location to see them in.
So it sounds like some type of controlled environment, basically.
Correct.
Okay.
Yes. Yeah.
And the other question is, if a homeless person is in a shelter and could benefit from home health, are there any street doctors that can order it? And I think this may be referring to the street medicine team, as far as doing the outreach and then seeing the need, placing the order if they get them into a respite location.
So the biggest thing is that they would need the ideal situation is they need to be in the respite program. Then they have to have the following physician. So if the street physician is willing and able, and I don't know, if it's coming from the clinic and you can get them into a respite program, we have to have a following physician. So somebody gives us orders, signs orders, etc. So we can call them up and say, hey, Mr. Smith has a wound on his left leg. I need, as a nurse, need orders for that. And I want to use these products. And then the physician agrees to it. So we have to have somebody that's going to follow ongoing issues and needs for continued things. So just putting in a referral, we need that ongoing follow-up from a PCP or somebody that's going to do that. So that's a lot of times where we get stopped. Even from the referrals from the hospital is the patient, because the person's been homeless for a while, they don't have somebody that they go on a regular basis to see, or they haven't established or seen somebody in 5 years. Well, they have to reestablish with somebody so that we have a physician be able to provide us orders and do something. So that becomes kind of a tricky area that we have to work on to be able to get them the services they need.
Yeah. And I see Rob Thompson, your hand is up. If you have a question, can you please type it in the chat box, and just for fluidity and keeping with that, and I'll keep going here. I'll get to your question as soon as I see it. Maurice asks if how many respite beds are there? I know the 2 locations are House of Charity and Hope House, correct?
Yes, and House of Charity used to not have, they used to be a males only, and then all the females would go to Hope House. But now House of Charity has a female respite section and a male respite section. I don't know how many there are bed-wise in either location. I do know that some are paid for by the Providence system and some are paid for by Multicare at House of Charity, but I don't know which ones are which. I don't have that information. I'm sorry.
Yeah. And Rob Thompson's question, maybe I can help answer this as well. Does the House of Charity and Hope House have on-site nurses? I know they don't have paid staff who are RNs, but I do know that they do sometimes have students come in through WSU and provide some support. And I know that the street medicine team also does rounds within there. I see another question is, can an ARNP or PA follow a person make the orders for VNA?
Yes, they can.
Okay, perfect. And then let's see here. I think I missed the question. Let's see. Homeless person is in a shelter, could benefit from home health. We did that one. So you need a following physician to make a general population shelter person get services.
So somebody, a provider, MD, DO, ARNP, PA has to do the referral. The respite bed situation is a little tricky because you have to have either Multicare or Providence paying for that respite bed. So I think that's kind of where Robert and Chuck and Kimber get involved, because you have to have some type of, you have to have a way for them to get into that respite bed. And I don't know the details of that. That's been something that we've been trying to figure out and work on to try to get some more of these people into those beds and to utilize them.
Yeah, definitely. I know that's part of ongoing discussion, is those initial referrals, at least on the Providence end, come from Sacred Heart into respite beds. Sometimes if there are respite beds available, part of my role is to advocate. If there's a significant number of beds open and we see a patient here in the clinic that needs that, then I reach out to, her name's Kathy McEnroe and Kimber, to get that initial referral in. And so with that, I want to jump in real quick, briefly to the following physician. What does that process look like as far as getting to a physician? Because with this population group, it sounds like the primary concern is not having a physician available to follow the patient when the orders come through. So with the medical neighborhood around our location, you have, as far as primary care providers go to follow, you have Chaz Denny Murphy in the teaching health clinic that primarily serves this population for primary care. Is that correct?
Yes, that's what I normally see for them following up and going to. A lot of times the teaching clinic will do a quick establish of care at the hospital, and then they'll have a follow-up appointment later that we have to make sure that they go to once they get at the House of Charity in a respite bed. Or Chaz will say yes, and then they have a follow-up appointment that they need to make that the respite coordinators ensure that the patient goes to.
Yeah. Awesome. Well, and then I see one last question. Do we have any credible estimate of how many respite beds are needed to accommodate homeless patients? Are there sufficient beds available right now?
I don't know the answer to that. My guess is Robert probably knows better, but I would probably say not, but I don't know that.
Yeah. And I don't want to speak on behalf of other organizations providing respite beds. But yes, that's a very valid question to know, and to have that information ready, it would definitely benefit the coalition to have that. So I will do my best to advocate and reach out to give that answer, or to encourage the organizations to provide that information. But thank you, Amy, for your time and your service to our community members. I know within the medical system, it seems like we're system jumpers and navigators trying to navigate through our own internal barriers sometimes. So thank you for your willingness to do that.
You're welcome. Thank you.
Yes, perfect. And lastly, maybe is Sarah Clement Sampson on with us?
I'm here.
Awesome. Thank you, Sarah, for being here. Sarah, you have been, I think you were at our actually last in-person Spokane Homeless Coalition meeting before COVID hit. But thank you for taking time. I'll let you introduce yourself, and maybe you can kind of give answers to that respite funding and how many beds, at least on the Providence end, are available within these locations.
Yeah, so I'm Sarah Clement Sampson. I'm the Community Health Investment Manager for Washington, Montana, Providence, largely focused in Spokane and Stevens County. And what that means is I do a needs assessment and look at how we partner to address the needs in the community. And so that's where I've been involved in respite since the beginning. And it was really to address some of those questions around appropriate care. If you or I, any of us that have a home to go to, were able, we would be discharged from the hospital. And so that's really what started this off. But a lot of the homeless people, we knew that if we discharge them back into the streets, they have a wound, they have some of these things, they would just be right back in, and they didn't have a place to heal. And so this was developed really to allow for someone to have that ability to heal. And then along with it, have the partnership from those agencies like Catholic Charities and Volunteers of America to set them up with additional services. Is that primary care? Is that behavioral health? Is that substance abuse? Is that housing? And that was a big one, is we really wanted to allow an avenue to capture people when they are in a moment of making a change and willing to make a change, and then work with them on that and potentially get them into housing. And so we are funding 13 beds at Catholic Charities and 6 beds at Hope House. I don't know how many Deaconess is funding. And with that, we are in the data. We're working with Catholic Charities in particular around how do we get the data, because there's flows with this. And so there are days where there are weeks where it is full, we cannot get anyone else in. But there's also weeks that beds are available and we want those beds used. And so that's where we are working with Robert around how can we create some of these avenues to get even more upstream, because the reason for it being developed was around how do we get people in these acute conditions healed, in that safe environment. And so from the hospital. And so, but we recognize there are times when it's open. How can we potentially get upstream, like some of those people that may not necessarily come to the hospital? And along with this, because it's been around for 8, 9 years or so, how do we adjust with, we want the homeless, when this started, ACA was maybe just coming out, people were just getting access to Medicaid. What did that mean for them? When I went out and talked to people at that time, there was like, why would I use this? I've been told no for so long. And there's, we're working on that adjustment of, you've been told no, how do we get you into better, more appropriate care that can follow you, can build a relationship with. And with that, if they're building a relationship like at a place like House of Charity Clinic, and they see something like frostbite or something like that, how could we get them into that care so that they don't have to come to the hospital? Because ultimately we want appropriate care where it's needed.
Awesome. And I see there's a question in there. How often are respite beds full, and where do they go then?
Oftentimes they stay in the hospital. So sometimes we will, if it's something we need them, then we will keep them, we'll push to keep them in the hospital a little bit longer, or we might have to discharge them if we don't have anywhere else for them to go, or general homeless or general shelter, general population. But we try as best we can to give them the care that they need.
Yeah. And another one is there respite beds with basic medical care, example, folks who cannot completely care for themselves.
So in the start of this, because there's been a lot of iterations and, learning, because this was really a pilot and we were figuring it out as we went. Catholic Charities did start off with a nurse. And what really came down to is insurance and liability coverage. And so for us to fund anything, we are the medical providers. And so we will provide that medical care. We want to be that medical care. Places like Catholic Charities, VOA, they are shelter specialists. And so we want them to provide that shelter. And so we really want to keep that distinction around that. That's one of the things that, as I mentioned we do the needs assessment. One of the things that we are really focusing in on is this population, the elderly that are maybe in skilled nursing and they have behavioral health issues. They get an acute condition, they come to the hospital, then the skilled nursing center facility doesn't take them back. We can't in good conscience release them to homelessness because potentially they were housed up until that. They had a house, they had all that, they had to go into skilled nursing. And so we are looking at what are some partnerships and possibilities around kind of that, I think it's maybe a medical assistant care where it's kind of that care for bathroom usage, for bathing, for, they might need help eating. They might need help with some of that sort of stuff. So we are looking into some of that. What would that level of accreditation need to be? What are the skill sets that are needed in there? What does the building structure need to have in place for that? All around some of those liability issues. But that is a need. That's a need that we're seeing. That's where we get some of the people that stay in our hospital for 400 plus days, which is not appropriate for them, but where else are we going to put them? And so we will take on that cost and that care. And so those are some things that we are looking into.
And that's when kind of like if they're in that long, that's when, the attempt to home and community and placement that way. And so is it safe to say then that when these respite beds first became available through Providence at these locations, one location in particular, the House of Charity Shelter, it was when it first was rolled out with the respite, was the clinic basically inside of the shelter then at that point?
Yes, the clinic was inside. And so that nurse practitioner would go downstairs, kind of work with, and so when we moved it out for better care, better documentation, all of these things, we really wanted to work with how we would work with all of those and keep it very close to that shelter still. And then as Catholic Charities was building their housing, how could we potentially work with those housing buildings as well, and the case managers that work there.
I'll just do this last question is one of the stories I keep hearing is that someone has an emergency where they end up in the hospital for a period of time and miss a rental payment, and then they end up homeless upon release from the hospital. They've lost all their belongings in their home. What kind of safety nets are available to help folks in this kind of situation?
I think I would have to lean on the social workers for this, and potentially the agencies out in the community, because I know like our social workers are trying to connect with those agencies and hearing of those things. Sometimes our foundation will step in to help with small amounts or to help some of that stopgap. But I'd have to refer to our social workers for that.
Yeah, that's a good question though, John. Thank you for asking that. And thank you, Sarah, for taking time to be with us and give us a little history and background and all that. Any last words or comments?
No, I'm here anytime if you have any questions or anything. That's what we want to do is be able to help ease the way for all of our people in our community, and for all of you, what are the trends that you're seeing? How can we start addressing those? Exactly like Julie Garcia mentioned, that's one of the things we're looking at, and how do we better address these things? And the way we understand it is when you guys let us know and tell us and hear this information and data. So thank you. Thank you all for all the work that you guys are doing. We can't do it alone.
Exactly. Thank you so much, Sarah. All right, so we are at the end of our meeting. Thank you so much. Real quickly, I just want to mention that we are going back live in person. That will be either in June or July. So I am super happy to see your faces again. But not only that, we are going to keep this live on YouTube so people can tune in. We have the tech to do it. We have the tech savvy people to keep it on. And so those updates that we get, we're going to attempt to keep those going with the COC, the health district, and with Mr. Lewis, because I know they probably couldn't come in person, but we would want to either record them and play it or have them live, give updates, and it will be again at the Gathering House. And so we'll keep you posted on what month that we decide to go back live. And I can't wait to see everyone's faces again as we go into the summer. So now I'm going to hand the virtual microphone for a post meeting, but also any organization updates. And then after the organization updates will be a continuation of the advocacy group of Stop the Sweeps with Dawn, and she'll continue, and Joan, to continue to facilitate that. That is awesome work you guys are doing. But if you want to continue to listen in, go ahead, but I'll leave this time now and Barry to take over when this part is over, to discuss any organization updates that you have. And thanks everyone. Happy May the 4th be with you, even though the 4th was yesterday.
Thank you, Robert.
Or the day
So,
before.
Announcements, brief announcements, because once I turn it over to the action group, Stop the Sweeps group, they have a lot of material, and I'm sure they want to delve into it and dive into it. And so I think they'll take probably the rest of the time. Sherry, you got your hand up.
I do, because I'm also in the Fair Housing Alliance or Fair Housing conference, so I have to get going. But we as Spokane Valley Community Advocates are putting on an in-person rental and utility assistance event on May 14th from noon to 7 at Opportunity Presbyterian Church. This will be for anyone in the county that's basically east of Spokane, north to Colbert Mead, down to Valley Ford, is our service area already, and that's the area that we're focused on. We are desperately in need of volunteers. So I have included information in the chat on how to get a hold of me. We are going to have 8 intake workers who are actually going to help them do the portal application with their documents. And then we will also have traffic control and front screeners. But those intake workers are really important. And if we don't get the 8 for each shift, then, you know, it's going to be chaos, because we're probably going to be busy. So if you're able to take that time and come volunteer, I would really, really appreciate having you guys contact me.
Thank you, Sherry. Julie Garcia, hand up.
Hi, I just want to let the coalition know that JAH received a giant amount of single survey.
You're muted, Julie. Somehow you got muted.
Did
Go
you hear
ahead.
that part? Okay, of protein. So if anybody or their clients are in need of food boxes, we have an excess amount of that product.
Okay, so contact you and you can arrange pickup. Or did
Yes,
you deliver?
sir. Either one. Thank you.
Thanks. Anybody else? Announcements like that before we turn it over to Stop the Sweeps? Going once, going twice.
Can I say one more thing?
Surely.
Okay, so I don't see anybody from Spokane Valley Partners here, but on May 15th, Spokane Valley Partners is doing a massive food and clothing blowout. They're basically clearing out their warehouses, diapers, they're gonna have vaccines available. So that is May 15th, and I'm sure there's information on their website, but I don't have it handy. So I'm sure if you show up after 10 o'clock, just follow the cars.
Yeah, or Google Spokane Valley Partners. All right, going once, going twice. Other announcements? Okay, Dawn, Joan, and all. Tell us about Stop the Sweeps and the action group.
Hi. So, wow, that was a really informative meeting. I really appreciated everyone's presentations and things that were shared. And there's so much exciting things going on with what Ben was talking about and the thing that he's putting together. That's just really, really exciting. So I just wanted to share that first. So here's our petition. And I've put updates in the email group about all the details and everything. We have this big QR code on the back of our petition boards now, so that if people are in a car and they're stopped at a stoplight and someone's on the corner getting signatures, they can actually use their phone from their car and hook up with our website through the QR code on the back of our petition boards now. I just wanted to touch real briefly on what a couple of the main thrusts of the petition, and one of that is that all of our asks are very immediate asks that can be implemented very, very quickly. Like some of them could be implemented within a week or a couple of weeks. Basically, however long it takes our officials to authorize the funds and make things happen is how quickly these demands can be implemented. They're not demands that are going to take a long time, like building a new shelter or changing laws. We're asking our officials to suspend laws that criminalize people for being homeless and take immediate action in getting those toilets and storage containers and garbage containers and garbage service out onto the streets and identifying places where people can be. So some of the feedback that we've been getting from people are concerns about, well, we don't want people camping on the sidewalk and blocking the sidewalk and blocking people from getting to where they need to go downtown. And well, we don't want that either. And there are already laws on the books that make it illegal, make it a crime to obstruct the right of way and obstruct a sidewalk. The people who are camping downtown are generally not blocking sidewalk access. They are in easements. They're in those areas between the sidewalk and the road, or they're in a plaza kind of area off of the sidewalk, the main sidewalk, such as underneath the freeway. So they're not blocking doorways, they're not blocking sidewalk access for anyone. So part of the demand also is that we identify places where folks can exist if they're homeless and on the street outside and they're not sheltered. This is a very important ask because currently there is no such place in the city of Spokane designated for people to exist outdoors. All of the parks are off limits. All of the public areas are off limits, and nothing is actually identified for them to be at. So it's really important that the city and actually the county and the Spokane Valley, so this is a regional petition, not just for the city of Spokane, but especially in the city of Spokane that doesn't have anything identified, no place identified for people to be. That's a very important part of what we're asking. Is there anything else that I need to cover right now? Oh, some of the other complaints have been things like garbage and litter and human waste, and our petition addresses those issues of concern. We're asking for the city to supply toilets. I mean, people have to go. They're going to go somewhere. It's a basic human bodily function, and so toilets need to be provided for people. Otherwise, they are going to go, in areas that are less desirable than an actual toilet. And one of the things that happens with the sweeps, when the sweeps happen, is if there is any kind of human waste evident at the camp. So that includes like if they're using a bottle to pee in, if in that bottle is that container is sealed, that's still considered, you know, human waste, evidence of human waste. And that can be a reason for them to immediately sweep that camp and confiscate everything. So the toilets are a very important ask. The garbage and the litter, all the trash, you know, we don't have containers for people to put things in downtown, especially not in the areas where people are camping. There are no trash receptacles under the freeway or in these off the wall spaces where people are camping. And so think about how much money would be saved if the city just simply provided some garbage receptacles where they know people are camping, instead of having code enforcement accompanied by police 5 days a week, driving around and providing cleanup when the folks that are camping could be doing that for themselves if they had a container to put those things into. So
I'd like to real briefly, we do want to open up immediately to questions, and just any questions people have. We're responsive. We want everybody's voice heard, and we want to be involved in making sure you understand what's important is that we get enough buy-in, and we have to look at best practices. I'm seeing best practices the more I watch the frontline enforcement, like neighborhood resource officers are the frontline cops, and the frontline grunge work of dealing with homeless encampments is our code enforcement people. And I see some of the best practices as they're handing out bags to people to handle their own trash, as they're politely coming in and moving out, and just keeping things, you know, and the neighborhood resource officers are very skilled and adept and know many of the people they're dealing with. They also are the ones that see best practices among people encamped outdoors. And we need to work with them to find out how to lift up those best practices so that people understand what's expected and how to make it so you can be a hassle-free resident, member of our community, and still maintain your autonomy, and still and still, you know, not be a victim of a constant whack-a-mole game. And it's not the people doing the work of it that designed this. It's multi-generational. We've tried to change behavior of men and women who are experiencing homelessness, but even if we changed all the behavior, Ben's talk about the dynamics of our housing market, there is no possible way presently to house anywhere near 20% of the 1,000 people who are encamped on the streets. And it's just, it feels like violence, inescapable violence, to be a member of that right now. And that's no way to get people comfortable enough to open up to services. It's no way to meet the goals of organizations that need them to participate in let's move your life onto a track you want it on. And a better way is just to find best practices, lean into supporting those, and any kind of questions or involvement. We need everybody with skin in the game. My piece has been reaching out to mostly homies, mostly people experiencing homelessness, because it's only the beginning if we get any of these asks. And we need them to participate in owning that, yeah, these are our porta-johns, or this is our access that we need to keep healthy and available. And any questions, anybody wants to be involved, please jump in.
Before we take questions, one more thing I wanted to highlight is there is a shift that is happening. We are seeing a major, wonderful shift since even before we launched the petition a couple of weeks ago. I think it has to do with the transparency of our process, of the group, and all of the great people who are participating in our action group and working on the petition and working on Stop the Sweeps. We have folks from all sorts of agencies. We have folks from the streets working on this. It's this wonderful collaboration. And because we have been so transparent with the coalition and online about what we're doing, and in our communications to like the city council and the mayor's office, what we are doing has already come to the forefront of the attention of people who can enact these changes. And we were already seeing changes in how code enforcement are conducting the cleanup. We're not seeing confiscation of people's belongings as much. There's been a definite diminishing in those activities. And we've also seen a change in how the police are interacting with people, and it's been more respectful. And I'm taking a lot of heart in the fact that these changes are already happening, and there seems to be this shift in attitudes and mentality, and maybe a rethinking of how we can actually solve this problem. Because frankly, they've been doing these sweeps and making it, a criminal act to be homeless in this town for over 10 years. And nothing has changed and nothing has improved. Homelessness has increased in our community. And what's been happening is people are just basically terrorized and traumatized just from living on the streets because that's a crime. So this petition is very important, and we need as many people to sign on as possible. And if you are part of a group, maybe your work group, or maybe you're a part of a club or some outside group like that, if you can please take the petition to your groups and ask and see if you can get support for this petition, and get endorsement, get more signatures. We have more of these boards. We've got, another at least dozen or so, and we can make more of these boards. So if people want to take petitions, contact us, and we can get those to you. Ken will run them to you, so that you can be a part of this process. Because the more pressure that we can put on our officials to make these changes and make them quickly, the better off everyone's going to be. So thank you. And we'll open it up to questions now.
Barring any immediate questions, and please raise your hand and we'll respond directly. If it is that the shift that Joan described, there are allies that are moving on these issues in alignment in ways that demonstrate we've already changed. We've already come to realize that, whoa, maybe it's that we've realized we're in trouble, that our economy, we're in a situation where we really need to tend to how to in a responsible fashion move in a as a community on issues. But there's traction now that never existed that's required to move on these issues. And zoning law changes, that's one of the most intractable, challenging things you can do inside of a city. Zoning law changes, they're happening all over the country. Every city USA is prepared now to rapidly change zoning laws. That's a shift that the League of Women Voters, who's been kindly women who are doing nonpartisan voter guides and registering you to vote, is fighting for the rights of homeless men and women all over the country. And that's powerful. And it represents a shift that we need to lean into, so that it's something that it deals with our greatest concerns about it, because they're all valid. We all, but the status quo, it doesn't exist. It's a gray area now, and we need to make that a place where we can collaborate and be comfortable and feel a full part of. Everybody.
We're also having a meeting at noon. Our next action group meeting is at noon. And I put the Zoom link out in an email a few days ago. But if you need it again, you know, contact me. My email, I'll put my email in the chat here so that people can contact me if they want the Zoom link, if they can't find it. And again, if there's any questions that anyone has or any stories they'd like to share about Stop the Sweeps, we'd love to hear it. I think the synchronicity that is happening around this movement with not just Stop the Sweeps, but humanizing Spokane and the things that are happening with Ben and the continuum of care folks, and it's all coalescing into this really wonderful shift and movement. And I think it's going to take all of us working together, you know, not just a few of us, but everyone seems to be working together to move in this synchronized direction now, which is wonderful. It's a wonderful thing.
These guys with the coalition and the work you've done to keep this going, to get familiar and accustomed to the technology. We've all gotten an opportunity through this and through everybody in every workplace now through this pandemic environment to kind of taste our own salt, feel the humanity working through what had been largely impersonal mechanisms, this Zoom meeting. And maybe that's a part of it, because the sense I got when I was hearing the healthcare professionals talking about discharge and what's available once people are discharged, it was much closer up and personal in terms of how and accessible, from sitting at home on my couch to how those outcomes really are and the information about them and how those can be impacted, how they can change. And some of the tools that we've been having to use to have allowed a perspective shift that I think is really healthy. And I want to praise you guys, especially Barry, the work on making this all accessible. Thank you. This is a great opportunity, and it increases the oomph of all of everybody's work. We get to look back and say, really, there was that important thing, and those presentations can be seen much more widely now than ever before. Mm-hmm. And I'm glad you're going to continue doing that.
Yeah. Well, I'll tell you, one of what gives me great joy when we went to Zoom, I sort of took on this personal thing of like, let's do a little half hour before and let's just run it late. And it's like, that was my just commitment to do that. And the fact that Stop the Sweeps and the action group sort of grew out of, an after meeting time, that just, I am so pleased that something I tried to facilitate turned into this, which is awesome. So I am very pleased I had a little part in getting this happening.
And it happened so quickly. I mean, we were so motivated as a group. It just went boom, boom, boom.
Yep.
And I mean, when you think about it, it was less than 2 months ago that we started talking. Well, it was about 2 months ago exactly that we started talking about it, but it was less than 2 months ago when we had our first meeting as an action group.
Yep.
Yeah.
But it is the same vacuum that I mean, you're facilitating access to that vacuum for the COC and for Ben and his work with the housing on low-income housing, and for the the organizations that are working with the transition from healthcare to what a health outcome, and that those are vacuums that are drawing everybody in to some real opportunities and facilitating that. I bet that's exciting, Barry. Thank you.
So one of the change stories, success stories that I'd like to share is prior to last week, folks were not seeing notices. They were not receiving notices in advance of having their camp swept, and they were not receiving notices after the fact as to if their things were taken and stored, how to get those things back. And they're still not receiving a lot of those notices, but was it last week or was it earlier this week? I don't know. It was a handful of days ago. One of the folks who lives on the street, who is part of our action group, his name is John, he received a 48-hour notice from the police and code enforcement that his camp needed to be moved. And he, you know, it's so huge to have that, because what that means is he now has due process, which he never had before. If you're living in an apartment or a house that gets foreclosed on, you are given a written eviction notice with so many days to leave, and there's due process to that. You know, you can appeal it, you can go to court and fight it or whatever, or address it, get more time to get that done. And the folks on the street, they don't have any of that, especially without any notice. But with that piece of paper in his hand, with the date and the time and the
date and time certain.
Yeah, date and time certain. And John now had a piece of paper that gave him exact notice, not just some verbal threat or verbal warning that
you can't be here,
that you can't be here and move along. He now had 48-hour written notice. So that's huge. That is a really huge thing. And I don't think it would have happened without the Stop the Sweeps movement and the things that we're blowing up online and talking about, to help these folks.
He said, Ken, like a regular citizen, look. He was so excited. He was chuckling. He said, I've never seen one of these in my life. And he's been the victim of whack-a-mole for most of the last many years. Since his camp was evicted, was thrown into dumpsters on the 4th of March. He's had to move 3 times since he was evicted at that point. None of that included notice. It was just move it along. You can't be here. You're not welcome here. And it's a constant, oh my, when does this happen? And it's so stressful. And to have a date, time certain, okay, piece of paper, now I got it. At least it's being treated like you deserve notice that you might lose your belongings. You deserve notice that you might lose your liberty. And it's something that we all enjoy and cherish. It's a protection that, hey, that we demand. I'm not going to get kicked out of my apartment except if somebody evicts me. They got to go to court to do that. And gratefully, I haven't had it happen. It's terribly painful. I've seen it happen. But with homies, their stuff's already on the corner, on the street. And if they act like, oh, you don't need notice then. And they've acted like that in the past, but I'm glad they're changing that. Part of it is the courts have changed that, have started determining that, that we all have the same liberties and you don't need a lease or a deed. But it was really exciting to see John so pleased to have some of the trappings of citizenship arrive at his doorstep. I've never seen somebody so happy to get kicked out of his dwelling.
Yeah.
Oh my.
So I'll put it out there one last time. If anyone has any questions or anything like to share, this is your moment. Otherwise, or if there's something else you'd like to talk about, we can do that too. I guess Barry had to leave. It looks like he had to go to work, and he's handed off the meeting to me. So so now's your moment if you'd like to speak. Okay, I'm going to go ahead and close off the meeting and end the meeting then. And thank you everyone for attending and sticking around, and let us know if we can get you a petition or if you're interested in information that you can share with your group on our movement. So thank you. Maybe I'll see some of you at noon. Thanks. Bye.
So I was really